Welcome to this bradycardia management OSCE for AUT postgraduate paramedicine. Today I'm going to be discussing management of the bradycardic patient, the use of atropine, dopamine, adrenaline and sodium chloride in the management of bradycardic patients, the use of pacing and analgesia administration, and finally I'm going to take you through two different simulations with two different patient presentations of both wide and narrow complex bradycardias, and we'll discuss and demonstrate the treatment in both of these settings. Let's get into it. The management of bradycardia in the pre-hospital setting is determined by the underlying cause of the bradycardia, the age of the patient, the rhythm and rate of the bradycardia, and the level of cardiac compromise the patient's experiencing. The primary cause must be considered because treatment of this, if not cardiac in origin, takes priority. Examples of non-cardiac causes of bradycardia could include hypoxia, particularly in pediatric populations, hypovolemia and hypothermia, though in most geographic locations within New Zealand this is statistically unlikely to occur. The first thing we need to do for this patient, after completing an initial assessment, gaining a patient history and identifying that the cause of the patient's condition is a bradycardia or slow heart rate, is treat the patient with oxygen if they have clinically significant signs of shock. This needs to be done in conjunction with treatment of the bradycardia, but we can't ignore the patient's shock state. These two things need to be managed simultaneously because they're one and the same. We then need to obtain a 3 and a 12 lead ECG on the patient. We need to do this to identify cardiac causes of the bradycardia, for example, inferior wall myocardial infarct, and we need to identify the underlying rhythm itself. We might see wide complex bradycardias, for example, idioventricular rhythms or third degree heart blocks or AV blocks. Narrow complex bradycardias that we might find include sinus bradycardia, sixth sinus syndrome, nodal bradycardias, and second or first degree AV blocks. As some rhythms can be difficult to distinguish between, the national guidelines for paramedics make mention of narrow and wide complex bradycardias. This is because some rhythms can be particularly difficult to distinguish. For example, idioventricular rhythms and the changing and dynamic morphologies that we see with hyperkalemia, for example. These rhythms, though their treatment is inherently different, identifying them can be particularly difficult and confusing for the ICP. Therefore, these statements made about undifferentiated bradycardias remove the ambiguity here, making management and treatment decisions less complex for the intensive care paramedic. Now we have as much diagnostic information as is available to us, we can gain IV access and begin to treat the patient. While I'm gaining IV access, I'll usually elect to have my crewmate set up and prime a 1 litre bag of sodium chloride. I can either use this later down the line as an adrenaline infusion, or I can use it as a fluid bolus in the treatment of cardiogenic shock. Either way, by keeping as many hands busy as possible, I'm able to free the hands and the brain of the ICP, allowing me to make complex decisions within the safest environment possible. Atropine is currently considered to be the gold standard of care for patients with unstable bradycardias, coming with a Class 2A level of evidence from the American Heart Association. Atropine is an anticholinergic drug binding to and blocking muscarinic acetylcholine receptors, particularly within the vagal nerve. Because of its anticholinergic effects, atropine abolishes bradycardias, some atrioventricular blocks, and provides symptomatic relief for patients with organophosphate poisoning. Atropine does produce some level of blood pressure increase, but for management of your patient, if you require a clinically significant increase in blood pressure, you need to administer it in conjunction with a positive inotrope. To administer atropine, we give a 0.6 milligram and 1 ml IV bolus. If atropine has effect for the patient, we can administer this as required with no maximum dose. Adrenaline is an adrenergic receptor agonist, acting on the alpha-1,2 and beta-1,2 adrenergic receptors. The beta-1 effects of adrenaline increase dromotropy, lusitropy, inotropy, and chronotropy. The inotropic effects of adrenaline, when paired with the peripheral vasoconstrictive effects of adrenaline, cause an increase in blood pressure and global perfusion. Adrenaline has a Class 2B level of evidence from the American Heart Association in its treatment for bradycardia. Adrenaline is administered as an IV infusion in adults by placing 1 milligram of adrenaline into a 1 litre bag of sodium chloride, typically administered at 1 to 2 drops per second, and then titrated to effect. Sodium chloride is the final tool in the arsenal of the New Zealand ICP for the management of patients with bradycardia. While sodium chloride itself isn't a treatment for bradycardia, it can be used as a mode of increasing inotropy in these patients. Increases inotropy and global perfusion through the Frank-Starling effect, which is useful in shocked patients, for example patients with a decreased level of consciousness. The administration of sodium chloride is fast, easy, and is relatively safe, so you can task a crewmate, for example, to do this for you while you're doing other things. You may want to consider placing bilateral IVs in these patients if you're going to be administering sodium chloride and adrenaline simultaneously, for example, as it allows for both of these things to occur at the same time. To administer sodium chloride, we follow the cardiogenic shock procedure, administering 250 to 500 ml of sodium chloride up to a maximum of 1 litre, as long as these patients don't have adventitious sounds in the lungs. The final drug I want to talk about, though it isn't currently carried by New Zealand ambulance officers, is dopamine. Dopamine is a catecholamine neurotransmitter that's predominantly administered in the treatment of shock for its positive inotropic and chronotropic effects. Because of these effects, dopamine is used in the treatment of bradycardia, either when atropine isn't available or when atropine fails to have effect. Like adrenaline, dopamine has a Class 2B level of evidence. Okay, after talking through some of the general management of the bradycardic patient and the related pharmacology, it's time to talk through a couple of different patient presentations and scenarios. So patient A here is a 78-year-old male who has had a syncopal event after getting out of bed this morning. He woke up on the floor and pushed his medical alarm that he's never used before. He usually keeps fit and well, lives an independent lifestyle, and hasn't been unwell for some time. Patient A here takes aspirin and atorvastatin and no other drugs. We've completed an initial assessment and his vital signs are as follows. He has a respiration rate of 26 per minute, a heart rate of 36 and irregular, a blood pressure when lay supine of 65/50. He has a GCS of 15, a blood glucose level of 5.9 millimoles per litre, and a tympanic temperature of 36.5 degrees. He has weak brachial pulses on palpation. Patient A has no recollection of experiencing any prodromal symptoms, chest pain, shortness of breath, palpitations or lightheadedness before this event. I've acquired a 3-lead and a 12-lead ECG on patient A, and I can see that he has a complete AV dissociation or a 3rd degree heart block. Patient B is a 56-year-old male who's called an ambulance at work today because he has worsening epigastric pain and nausea. He's been taking antacids for this all day with minimal effect. Patient B is an ex-smoker. He suffers from depression and takes amitriptyline for this. He also takes other cardiac medications, but he can't remember their names. Patient B has a 2-year history of MI. He remembers that he was flown to Waikato Hospital last time and that he had 2 stents put in. I've taken some vital signs from patient B and have the following: respiration rate of 32, heart rate of 38 and regular, a blood pressure of 70/50 with weak radial pulses, blood glucose level of 9.1 millimoles per litre. He's saturating at 92% on air, so he's on 2 litres of oxygen via nasal prongs, which have raised his blood oxygen saturation to 95%. He's got a GCS of 15 when sat upright, a temperature of 35.9 degrees, which could suggest that he's got decreased central perfusion going on there, and he has pale, cool and clammy skin. I've taken a 3-lead and a 12-lead ECG from patient B, and I can see that he has the rhythm he's in is a sinus bradycardia, and that he's currently having a inferior STEMI. For both patients, I've gained IV access. I'm administering oxygen titrated to a level of 95% or above, and my crewmate has set up and primed a running line of sodium chloride that I'll use in the event of persistent hypoperfusion or shock, despite my management of the bradycardia. Patient B has had an aspirin. Both patients are deemed to be status 1. Transcutaneous pacing is the gold standard of treatment for patient A, while Atropine is my treatment of choice for patient B. This is despite the interaction between the tricyclic antidepressant that the patient takes and the Atropine, where the antidepressant potentiates the anticholinergic activity of the Atropine. Atropine isn't used in the treatment of wide complex bradycardias due to the likelihood that it won't have any effect on 3rd-degree heart blocks or AV dissociation. In this setting, what might happen is that the atrial rate is increased, but there's no improved synchronicity between atria and ventricles. I have the defibrillator pads on patient A, my defibrillator ready, and my transcutaneous pacing checklist open. In the event that the patient requires pain relief, I'll administer fentanyl, which is the preferred opiate here due to the patient's level of physiologic instability. Okay, so let's go through that now. So I have the pads placed in the apex sternum position. I've selected the pads on the monitor, which has the largest visible R wave. Select pacing. Confirm there is a detection symbol above every QRS, which I can see here. Confirm pacing is in demand mode. Set the pacing rate at 70 per minute. Select current and increase this until pacing capture occurs. Confirm there is a pacing spike before each QRS symbol. Right. Increasing the milliamps. Okay, I have capture, so I'm going to increase it by 10 milliamps and select that. Administer fentanyl if there is significant pain from pacing. Add low doses of ketamine if required. Confirm there is mechanical capture with palpable pulse and improvement in the SpO2 waveform or other signs of increased cardiac output. So I'm going to feel for a central coronal pulse, which I can feel here. If I couldn't palpate a pulse, what I would do is increase the rate of pacing to 80 just until I could palpate a pulse. Change to fixed or non-demand mode if pacing is ineffective due to artifact. I don't need to do that because my pacing's been successful. Okay, so pacing in this patient has been successful in the management of this bradycardia. If pacing was unsuccessful, I would administer intravenous adrenaline, which I've already drawn up, and I would administer it as I've already previously described in this video. As the rhythm of patient B originates above the atrioventricular node, it's more likely to be responsive to atropine. As such, I'm going to administer a 0.6 milligram dose of atropine as an IV bolus and monitor the patient closely for improvement. If improvement does occur, then I can administer further 0.6 milligram doses with no maximum dose for this patient. If the bradycardia is unresponsive to the atropine, what I'll do then is administer adrenaline via an infusion. If that still is not effective in managing the bradycardia, I will elect to pace the patient using the same checklist that I've just used for patient A. There are a few caveats to the patient management algorithms that I've described in this bradycardia management OSCE video. These include, but aren't limited to, beta blocker overdose, calcium channel blocker overdose, and hyperkalemia. In hyperkalemia management, we administer glucose in conjunction with calcium chloride. This stabilizes the myocardium and corrects the resting membrane potential of the cardiac myocytes. This increases the speed of conduction through the nodal tissue of the heart and allows for the return of a normally perfusing cardiac rhythm. In the management of beta blocker overdose, we administer sodium chloride in conjunction with adrenaline. We administer adrenaline for its beta agonistic effects. We may need to administer the adrenaline at higher than normal doses. This is because of the beta antagonist effects of the beta blocker itself. Though adrenaline is described in the New Zealand medic guidelines as the first-line treatment, the National Ambulance Sector Clinical Working Group haven't actively discouraged pacing or atropine in the management of the bradycardia in these patients. Finally, calcium channel blocker toxicity or overdose is treated with calcium chloride, calcium ions again. This calcium chloride should be administered in combination with an inotrope, adrenaline, if the patient has clinically significant signs of shock following calcium ion administration. And I'm done.